Assalamu alaikum students. Today we are going to learn something about coagulation disorders. Coagulation makes the blood gel-like and then solidified so that we can seal the blood vessels and we don't lose the blood. It's very precious. It must remain within the blood vessels, nowhere outside them. So some relatively common diseases that would cause increased or longer amount of bleeding for a longer period of time. Hemophilia 1, okay, warm development disease, inherited bleeding disorder. Again, people bleed longer or more often due to this problem, this disease. Factor 8 along with warm development factor complex, they go along with each other, actually together in the blood. The VWF stabilizes factor 8 and increases its half-life. That's very important. In addition to working uh, together in this way. Hemophilia, VW, or von Willebrand disease, most common inherited disorders. A qualitative problem usually affects rate more so, and a quantitative defect affects von Willebrand factor usually, although qualitative defects can also occur uncommonly. Bleeding, you see, they have compared that bleeding is increased in such a disease. Although they exist together in the blood, but they are encoded by separate genes synthesized in different cells. And actually, von Willebrand factor increases the half-life by attaching to it, that is factor 8. The half-life of factor 8 to 12 hours. Otherwise, alone factor 8 can survive about 2.4 hours in the blood, or half-life wise. So, if factor 8 is not there, even normal quantities of, sorry, if one factor is not there, even normal quantities of factor 8 will be not able to initiate coagulation. They won't be able to do their work properly. Their quantity decreases. Sinusoidal endothelial cells, Kupffer cells, that is in the liver, and tubular epithelial cells of the kidneys are important sources of factor 8, while von factor is made in basically endothelial cells and megakaryocytes also, because platelets do have this factor. As you see in the diagram, von Willebrand factor attaches platelets to it, provides them with a base, and it provides them with a chance to stick to them. That is a polymorph of von Willebrand factor and subendothelial tissue, especially collagen, the protein collagen, so that they can plug the gap, plug the hole. Then other factors can come and cover it up with ropes and cells in between, so a seal can be made. And no bleeding is done here afterwards. The proteins with which von Willebrand factor interacts with the platelets is the glycoprotein 1b9 and on the platelets itself and matrix components of the collagen. So they form sort of a chain. Platelet aggregation is also improved by the von Willebrand factor, and it binds to activated GP2B3A integrins on the platelets, adhesive proteins. Symptoms, common symptoms of the disease: bleeding from mucous membranes, increased bleeding from any holes, any injuries, surgery. So, mucous membranes may be epistaxis, excessive bleeding from wounds, menorrhagia, surgeries, anything. Dental procedures, prolonged bleeding time in the presence of a normal platelet count. Usually, it's an autosomal dominant disorder. Not always. It has more than 20 variants that are now known. There are rare, uncommon autosomal recessive variants too. Different types, type 1 autosomal dominant and type 3 autosomal recessive, are associated with a reduced quantity of circulating warm blood factor. Type 1 remains mild to moderate because it's autosomal dominant. It shows incomplete penetrance or variable expressivity. There is no normal allele. Type 3, which is recessive, is severe form because there is no normal allele and the amount is too less for warm factor. Type 1 accounts for about 70%, type 3 is uncommon, and type 2, as we'll see, accounts for about 25% of the total diseases or cases. Now, severe deficiency of hormone factor has an effect on the stimulative factor rate. If you remember, we just mentioned that they both go together. Now, factor rate will also not work properly because its half-life is less, and very similar symptoms will be seen. So, characteristics resemble those in hemophilia in this disease too. Type 2 disease, hormone factor has a qualitative defect. Most common and quantities of hormone factor are normal, but due to defects at genetic level, 2A is the most common among type 2, to be more specific. And quantity is normal, but multimer assembly is defective. When it is defective, what happens is that less size is achieved for making the multimers, smaller size is achieved, and they cannot hold on to platelets adequately. 25% of cases are of this type. Mild to moderate bleeding is seen in these cases. Waterford disease has defects in platelet function despite a normal platelet count. It is because probably it has got a role in activating platelets. They become more effective. Plasma level of active warm factor is reduced when reduced into, again, factor 8, as we already mentioned, is also affected. Variation in disease severity is seen within the families, different family members. So the intensity is different among different patients greatly, even within the families. Plasma concentrations, plasma concentrates are given for treatment, and another drug, desmopressin, is also given. So which also stimulates and controls this condition. Plasma concentrates have got hormone factor fresh, so for a time being, they are also very helpful. Hemophilia. Hemophilia is the most common hereditary disease associated with life-threatening bleeding. So even more than the hormone factor. Factor 8 deficiency. Now factor 8 works through factor 9, and as we saw that it turns 10 to 10A. And when this is stopped in between, it can cause bleeding, moderate to severe bleeding. It is inherited as an X-linked recessive trait, thus affects mainly males and homozygous females. Rarely excessive bleeding occurs in heterozygous females, and well, that is due to inappropriate lionization, as they call it. And excessive bleeding is seen in females only in this condition. 30% are new mutations, no family history. Symptoms: bleeds, bleeding gums, nasal bleeds, swollen stiff joints. Hemophilia A, it can bleed anywhere, everywhere, and it has got complications. Bruises, heavy menstrual bleeding, bleeding in the stools also, coughing up blood. That bleeding into joints will cause fibrosis, and later on deformities or decreased movements of joints is seen in serious patients. Variation in symptoms among patients is also seen here. If there is severe deficiency that is less than 1%, of normal levels are seen of the factor, and the disease is severe. 2 to 5% of normal levels have moderate to severe disease. Even just a few percent can control the disease to some extent. And those who have 6 to 50% of the factor have mild disease only. And around 50%, more than 50%, well, this is not a problem there. Symptomatic cases bruise easily, and trauma is going to cause massive hemorrhages. Well, quite a bit of hemorrhage. After operative procedures, you can't stop bleeding, so it has to be preempted. Something has to be done before, if procedures are to be done necessarily. Spontaneous hemorrhages occur in moderate to severely affected patients. Joints, as they move, there is pressure on the joints, so there can be a small amount of trauma known as hemarthrosis. Under the skin, petechiae as such small microscopic hemorrhages are not seen. Bruises are seen under the skin. Recurrent bleeding in the joints, deformities could be crippling. Hemophilia, joint with bleeding. Well, this is a better picture, and there's a bruise on the other leg also towards the left of the picture. And this is not good, a lot of bleeding under the skin, and this will be seen in the joint too. Hemophiliac people have a prolonged PTT, normal PT. So prolonged PTT is in intrinsic coagulation pathway. There is a problem with the intrinsic coagulation pathway. Extrinsic coagulation pathway seems to be working fine, but still it's only stimulating the pathway, not enough to create enough stimulation of the factors or provide support so that there is no bleeding. So intrinsic coagulation pathway provides a rapid thrombin activation, which stimulates factor 11 and 9 in the intrinsic pathway. So it also uses the intrinsic pathway, extrinsic one. Thrombin or less thrombin is produced due to defective feedback. It also decreases this thrombin activated fibrinolysis inhibitor, TAFI. Inadequate coagulation and fibrinogenesis, one of the processes of coagulation, and inappropriate clot removal fibrinolysis, another part of coagulation, contributes to the bleeding, diathesis, and hemophilia. Why clot removal? If we let the clot make within the body at one place, it can cover continuously the whole blood vessels in the body. It won't stop. So beyond the margins of the wound, there are factors which are antithrombotic. They will stop formation of the clot. That is very important. 15% patients with severe hemophilia have antibodies that bind and inhibit factor VIII. So another problem. Factor VIII even more so will produce a serious disease. Treatment: recombinant factor VIII infusions. Hemophilia A, hemophilia B, that is due to factor IX, hemophilia B. Christmas disease or factor IX deficiency. Now, factor IX deficiency produces a disorder which is clinically indistinguishable from factor VIII deficiency, because 9 is stimulated by factor VIII, helped by factor VIII. So symptoms are not different. Only by testing you can find out that what is the exact etiology of the problem. Inherited as an X-linked recessive trait, hemophilia B, factor IX deficiency, X-linked recessive trait, variable clinical severity, mild moderate is also seen in this patient, and 15% of the patients factor IX is not functional, it is present but it's not functional. Again, there is some genetic problem. PTT is prolonged in this disease. Again, intrinsic pathway is affected and it's treated with infusions of recombinant factor IX. So hemophilia A and B both are treated with recombinant factors of the coagulation cascade 8 and 9. That's all for today, and we'll join later. Khuda Hafiz for now.